Hello, everyone. I'm Todd Didier, Communications Director at the Primary Care Collaborative, a national organization that convenes voices from across the healthcare landscape that are committed to improving the nation's health by strengthening primary care. I'm thrilled to welcome you to today's discussion on how teams and technology can be deployed to lower administrative burden so that value-based care can be a better experience for clinicians and patients alike. A few housekeeping items before we get started. This session, like all PCC webinars, is being recorded. The recording will be posted on our website, thepcc.org, within 48 hours. You can also find all of PCC's previous webinars on our website. We'll be taking questions using Zoom's Q&A tool, which is usually found at the bottom of the screen. Panelists will answer questions at the end of the webinar, but please feel free to send questions throughout the entire conversation. Chat has been disabled for viewers, but our team will be providing links to relevant resources throughout the webinar in the chat. So please keep an eye on that box. The PCC is committed to delivering high-quality webinars exploring important topics to the primary care community. We'd appreciate if you took a minute or two after the webinar to fill out the post-webinar survey so that we can ensure we're meeting that standard. Finally, within the next week, the PCC will be sending out a survey asking for insights into how you have been impacted by administrative burdens. This survey will advise a larger project we're working on exploring potential solutions to streamline value-based programs. If you could please take a few minutes to fill out that survey, it would be incredibly helpful to our team here at the PCC. Now, onto our webinar. Moderating today, we are excited to have a physician leader whose day job is to support clinical teams in a large health system to deliver more integrated, coordinated, and high-quality care. Drew Albano is also serving as PCC's first Rich Barron Fellow, and we're grateful to the ABIM for the opportunity to have Drew's expertise on loan to inform some of our most important work. As PCC considers how our collaborative can promote and advocate for changes that reduce administrative burden and unleash the power of primary care teams, Drew's experience leading a Medicare ACO is very valuable to us. I'm going to go ahead and give the mic to Drew, and he'll introduce today's panel, which includes representatives from leading health tech companies that recognize how critical primary care teams are to making value-based care succeed across the domains that are important to patients, payers, and clinicians. Drew, thank you so much for joining us, and handing it off to you.
Thank you so much, Todd. Good afternoon, everyone, and thank you for joining us for this important conversation. I'm thrilled to be here moderating the discussion. As a physician and ACO leader, I'm all too familiar with how administrative burdens can undermine the effectiveness of primary care. Briefly, I'd like to take a moment to introduce our panelists. First, I'd like to welcome Lisa Barry, who serves as Head of Policy and External Affairs at Innovaccer, where she leads health and AI policy and government relations. Next, I'd like to welcome Dr. Yair Lewis, who leads the medical team at Navina, where he is responsible for all medical aspects of product development and strategy. Last, and certainly not least, I'd like to welcome Dr. Sarah Pastor, who is Elation's Head of Primary Care Advancement, a longtime advocate for primary care, and a practicing physician. To start, in your own words, can each of you give us two-sentence description of what your organization does and what your organization is trying to achieve? And we'll proceed in the order of the introduction. So Lisa, if you don't mind, would you please share a little bit about yourself and your organization?
Yeah, absolutely. Great to be here with all of you. So Lisa Berry, I lead policy and external affairs for Innovaccer. Innovaccer is a health AI platform with a deep bench in value-based care, population health, lots of experience serving health systems, providers, clinically integrated networks, and also increasingly payers and public sector. And for myself, I've been, working in this field for a long time, including including previously leading Civitas Networks for Health, which is a national nonprofit member organization serving the nation's health information exchanges, quality improvement organizations, and health improvement collaboratives. And I also previously led health interoperability and health tech and AI policy at the CMS Innovation Center, working on some important primary care models now about a decade ago. So very familiar with the area, spent a lot of time working directly with primary care physicians and practices on specifically issues around reducing administrative burden and getting the data connected, which is a passion of mine, and very familiar with the work of my co-panelists here. And so I'll pass it on.
Thank you, Lisa. Yair, would you mind going next?
Sure, thanks, Drew, and thanks for having me. So, my name is Yair Lewis. I'm Navina's Chief Medical Officer. At Navina, what we do is we empower organizations to succeed in value-based care with use of AI. And basically, what we're doing is we have a physician-facing platform that is sort of a physician AI physician co-pilot. We're taking in different data sources, clinical data, claims, HIEs, and then running it through Navina Engine and being able to both summarize patient information and also output actionable AI-based insights to the point of care inside the EHR workflow. So excited to be here and be part of this discussion. I'm going to pass it back to you.
Yeah, thank you, Yair. Lastly, Sarah, if you wouldn't mind just giving a little bit about your background and your organization.
Sure. Hi. And thanks for having me. Sarah Pastor, I'm a family physician. I still practice part-time, but in my day job, I am the head of primary care advancement at Elation Health. And Elation is a primary care focused EHR, really built around the clinical experience and not built around coding and billing. We are AI native and really on a mission to rescue independent primary care in this country as a solution to help fix our broken healthcare system.
Very good. Well, thank you all for that brief introduction. Without further ado, let's get into some of the interesting topics that we'd like to discuss today. So first, Sarah, if it's okay with you, we'll start with you. As technology organizations, how do you view your role and how are your tools aimed at optimizing workflows to reduce administrative burden?
You know, the EHR really is the clinician's living room, and it's where clinicians spend most of our time doing most of our work when not directly focused on the patient. And this is especially true for primary care, where we're managing more tasks, more information, more collaborators per patient than any other specialty. So it's incredibly important that the EHR minimize the toil of doing that work and prioritize the clinician's cognitive resources for the work that directly impacts clinical care and supporting comprehensive longitudinal patient management as intuitively and effortlessly as possible. So to the extent that there are activities unrelated to clinical care, coding is a great example, the EHR should make that work invisible so that it happens by technical design, not by human effort. And to the extent that the clinical work involves cognitively draining tasks like reviewing large documents or rooting around in the chart to pull together disparate pieces of information in order to form a cohesive story, the EHR should streamline that work and minimize the effort involved. And there are so many other examples: inbox management, care coordination, clinical decision-making, schedule management, patient intake billing. These are all areas of potentially high effort that the EHR can and should make as easy as it needs to be. So this ease of use, minimal clicks, works the way I think experience is what has always been our focus at Elation, and it's what we've become known for. And today with AI, I think all EHRs have exciting new opportunities to magically erase tedium and toil, giving time back to clinicians to focus on the things that actually matter to patients and to health outcomes, and creating delightful experiences that suddenly feel like a superpower.
That's a great story, Sarah. And you touched on some really fantastic points. Obviously, for the theme of today's discussion is reducing or eliminating the administrative burden. And to your point, a lot of serve as a distractor from the core function, right? And you touched on that so eloquently. Yair, I'm interested if you have any thoughts from your perspective on your role and certainly tools optimizing workflows from your organization.
Yeah, so first of all, what Sarah just discussed sounds amazing, but unfortunately, most clinicians are still not using Elation. I'm sure you hope that one day they will all use Elation, but there's still a bunch of other platforms that aren't able to do all of that. And what we're aiming to do is with Navina is be that platform that is both optimized for primary care, but also optimized for clinician use in the setting of primary care. And as right exactly as Sarah described, being able to automate and streamline all of those parts of what a doctor needs to do, that are not patient care, that are not directly what you would like to do, which is, take care of the patient. So being able to read in instruction information connected to information coming in from different data sources, right? Because in many cases, you can have data coming in from a health information exchange that's sitting in this continuity of care document. Most physicians don't have the time or the wherewithal to go through these 17 pages because there's 10 different documents that are all very similar, but there may be some interesting information in there. That's just one example of things that Navina is able to do by reading those documents and connecting them in the right context to other information that may be coming from the EHR itself or from other information that the practice may have available. And that ties in with the ambient workflow as well, right? Everyone is ambient clinical documentation. It's definitely, this is the wave of the ambient clinical documentation, and this is going to be the future because it just makes so much sense to be able to transcribe that conversation. What Navina is able to do is connect it with the historical data, and that's part of what we're trying to do as well.
Yeah, thanks, Yair. It's very interesting you bring up the volume of data that's inundating our practices and our clinical teams, and it segues nicely into posing the same question to Lisa. In your role with Innovaccer, certainly you're dealing with large volumes of data, and I'm just curious if you can share with the audience your role and how some of the tools that you have over at Innovaccer are helping to optimize workflows and reduce some of the challenges that folks are facing from an administrative burden standpoint.
Yeah, absolutely. So Innovaccer and Navina are kind of what you would consider these third-party enablers across multiple systems of record. Elation is one of those systems of record. Of course, the line between EHR and health platform have started to really, really blur. Elation is a very unique EHR company with its focus. But if you think about what we do, we're really, at Innovaccer, we're really bridging multiple systems of record. When you look at a clinically integrated network, you're going to have doctors and clinicians on so many different systems of record, whether they're EHRs, others, ERPs, HR systems, all kinds of other systems that really power the data infrastructure of a particular healthcare setting. And so what's really important to us in reducing administrative burden is not only what happens in that particular individual clinic or hospital or health system setting, but also the entire network when you think about the way that we try to run referral systems and networks and all those things. And so it's really important that everybody can access the right data at the right time with the right level of context and specification. It's really, really important to do that fundamental, I would call it, data janitorial work, sort of bringing together all the different pieces across different systems of record. And so Innovaccer particularly has a decade of experience doing that work. And so that's bringing all the data, processing it, standardizing it, normalizing it, and creating a true longitudinal patient record, and then building all types of applications for clinicians and for other actors in the healthcare system off of that really continuous data. And a lot of that is, as discussed, right, figuring out what to bring in and figuring out what to actually surface at the right time. It's really dangerous if we have really important insights buried somewhere in the many different records or systems. And that's what's facing us today. And so it's not so much about like one particular application, but rather an ethos of we must truly connect all the different pieces of data and then make them available and then use our intelligence layers, our AI co-pilots, our AI agents, whatever else we have to make that right data, that right information available to the right person at the right time. And we just simply cannot accept anymore having physicians or clinicians digging through data, spending hours and hours, missing important things. We can't accept that anymore. So when we think about what is the administrative burden, it's all of that time. It's all of the risk, all of the danger of missing those really, really important pieces of data or information. And that's what we do at Innovaccer.
Yeah, no, very well stated, Lisa. And it's a great analogy when you're thinking about kind of janitorial in the sense of cleaning. It's really,
Right.
the goal here is, right, is to clean up, so much information coming in from variable sources. And how do we, not only clean it up, but then synthesize it into actionable information that, like you said, our clinical teams, our physicians can use at the point of care and can help, steward patients in their healthcare journey. And so I think it's, something that we're all challenged with, and I'm glad to see that we have such intelligent folks working on the problem at hand. Since the spotlight's on you, if it's okay, I'm just going to segue into our next topic of questioning. And so from your perspective or vantage point, what would be the top 1 or 2 reforms government could make to enable your company's tools to be more effective?
This is a favorite one of mine, and Sarah definitely knows, it's very, very important to continue to unlock data and information, right? We had a law in 2016 that led to sort of no information blocking regulations. This has been so-so in terms of how it's rolled out and the guidance around it. I think fundamentally breaking down, continuing to reinforce and provide additional specific guidance around how actors like us, like Elation, like many other EHRs, Epic, Cerner, Oracle, you name it, all of the above, right? We need to understand and really clearly have more clarity and guidance around those rules of the road and how we can truly make sure that we are not blocking information flow. And it's not totally simple, because when you think about, well, the work that we do, the work that Elation does, the work that other EHRs do, it's not free, right? We actually expend a lot of resources to move information around, to clean it, to make it available. So, okay, can we charge money for data flows? Yes, but there are specific rules to make sure that it's not information blocking. All the players need more clarity around those rules. We have to do more and more to continue to unblock information, specifically health systems, providers, those who are providing care and documenting that care. They're the legal owners of the record, but they often have to pay and have to work really hard to get information back and forth. That has to stop. So anything that government can do, anything that policymakers can do to unblock information, to provide that clarity to the healthcare business world would be really, really helpful. I think that's really important. I think secondarily, quickly, I would just say there's been a lot of focus around the technical side of interoperability, right? Data standards, FHIR APIs, USCDI. These things are helpful, but it's really only a very narrow sort of really narrow slice of the interoperability and data exchange world that is necessary. There are all kinds of ways to exchange data between systems. We need to exchange more data, not necessarily get super, super caught up in, are we aligning with a particular standard? It's appropriate sometimes, not always appropriate. So I would just say things that policymakers can do to just really push that flow of data versus necessarily limiting us to one type of network, one type of framework, one type of data standard for exchange.
Yeah, great points, Lisa. And I think one that we constantly are tackling in our respective work is just, who's truly the owner of the data? How do you get to access it?
Right.
Can you or should you be charged for it? So I think you bring up some great
sure.
points. And I'd love to get your input, Sarah. Similar question, just, again, what do you think from a 1 to 2 reforms that the government could enable your tools to be more effective, but also thinking about, as Lisa mentioned too, like what are some key stakeholders that we need to be factoring into, those decisions that are being, generated at the federal level. And so I'm just curious if you don't mind sharing your thoughts.
Yeah, well, first of all, +1 to all those things that Lisa said, and I'll just put my, clinician's spin on it. I hear my colleagues beating the drum about interoperability increasingly these days. It's a real pain point, and it's clear that their needs are still not being met, no matter how much we talk about this. And I share that sentiment myself. And, the information is still too hard to get, too late to arrive, too laborious to parse for what is relevant and actionable. And, Elation integrates with Care Quality, which supports a nationwide data sharing network. But even that requires labor to sort through and find what's important. And it certainly cannot be considered reliably complete. I mean, I'm never sure what's missing unless it's something I'm specifically looking for that isn't there. And clinicians, especially in small practices, struggle to comply with information sharing requirements. And so, Drew, as you and I heard in a meeting earlier this week, when patients file complaints, it's usually against the provider, not against the technology owner. And even though the provider may have little or no control over how and when information is being shared. So the government really needs to set clear national guidance and consistently enforce TECFA and make crystal clear the line between information blocking and lawful patient restrictions. So technology vendors can reliably and consistently build to those specifications, and clinicians can share the right data at the right time without legal confusion. So, as we all know, speaking of all the actors involved, the payer landscape is so complex. And today, different payers, CMS, registries, regulators all ask for different measures and different formats, which forces clinicians to navigate this confusing and conflicting set of rules and do extra work for very little reimbursement. And to be honest, it would cost less just to do the right thing for patients without that hidden tax involved in all that complex reporting. So aligning those definitions and measures, reporting across these groups in a similar way would dramatically cut down administrative burden and reduce burnout for practices. And this should include consistent expectations for what gets reported, how it's calculated, and how it's submitted.
Yeah, very thoughtful answer, Sarah. And I agree with you. As you mentioned from discussions earlier this week, it seems like, the obvious is apparent, right? But it just seems like the path to the obvious solution is very confusing and maybe less apparent. And so I think it's something where we have to continue to critically think about, who's responsible for what. How do we, put our, clinical teams, our healthcare systems, practices, et cetera, in positions of success, instead of, like you said, having all of these distractors and additional onuses that folks have to burden, that ends up, just undermining the true goal of the work, which is to improve health outcomes. And so I really do appreciate that thoughtful answer. Yair, I was curious if you don't mind commenting as we wrap up this topic, just thinking from like a federal level, what do you think are one or two things that really would be impactful for your company to fully leverage its capabilities? And certainly, if you could think about one or more key stakeholders that would play a critical role in addition to the government.
Well, first of all, I fully agree with what Lisa and Sarah had mentioned earlier, and I think I'm just going to segue from that and what you asked into. I will go back to the regulator and the government, because like we had this as part of the Make Healthcare Great Again and that stuff. We had this big announcement with the White House and CMS in July, I think, right, about kill the clipboard and a bunch of stuff. And yeah, we got a bunch of companies to sign up for this, but I did not see any sticks there, if you know what I mean. Right. So it's great that companies are signing up, but let's let's rewind to 2010 to 2015. How did we get organizations to transition to electronic medical records? Right? How do we did that because there were a bunch of stakes involved. There were carrots, but there were also stakes. And you can go, with carrots and you can go with stakes. But until I think we need to get a bit more of that, that's just my opinion, into the interoperability side, because a lot of these things are, and we need to, we need to make sure that the details are, are fully defined and that they make sense. Because some of the standards Lisa mentioned, for example, like the USEDI or stuff like that, it's sometimes, or Fire APIs even, it's somehow it's this, an EHR can be. And this is a big challenge for our company because we're integrating data from many different sources. So we're integrating directly with health information exchanges, right? And we've got different types of data coming in from there, mostly CCDA type data. Then we're integrating with electronic health records that on paper should all have Fire APIs available. And in order to be, in order for them to be get the certification, they pass some sort of automated test. But the reality is, and I hope I'm not, sort of shattering someone's, a grand, a vision of how things actually work in the background. The reality is that even if an EHR supports the Fire API standard, you're probably not going to be able to really use it in production for a multitude of reasons. So I think from my perspective, obviously, as was said, data interoperability is super important. It's a way to move forward. Everybody understands it. It's a pretty, it's a big task to see how we move this forward.
No, great points. And it actually segues nicely into a topic that's very prevalent in a lot of the work that you all are leading and that we're involved with. And it's really circling around or centering around artificial intelligence, agentic AI, and the like. And so I'm curious if we can stick with you for a second here. If you're looking at all these different key stakeholders, kind of standard setting bodies in healthcare, we have a variety of folks that are really integral to the direction healthcare is going. What approach would you like to see those stakeholders or those governing bodies take to ensure that AI is both trusted and effective in addressing the clinical administrative tasks that we see primarily in primary care?
Right. Yeah, so that's a super interesting topic right now, not only in the realm of medicine and healthcare, right? Because if you had a chance to see what David Sachs had just said about Anthropic the other day, that's the White House czar of AI. But I think in healthcare, it's, I think the pendulum is a bit too much on the conservative side right now. And everything that is tagged with AI is automatically causes, and maybe right, for understandably so, it's a new technology, but it causes a lot of consternation. And there's a bunch of barriers on the tech side and on the and also on the user side, provider, payer, whatever, organizational side, health system. I think, what would make more sense to me would be to sort of split up AI. Let's just not look at AI as this one, as this one monolith. So AI in healthcare, the way I see it, you can have AI that's autonomous or even semi-autonomous in guiding clinical decisions or making clinical decisions and interacting with patients, making utilization management, prior authorization decisions. We've seen a lot of companies go into that area. I think that's like I'd put it in one category. The other category is companies that just use AI to run in the background of what they do. Like, for instance, an AI that can extract clinical information from PDFs or ambient scribing for that matter. And the risk of harm is very different between those two groups. And I think obviously the first group, there's a lot of reason to think about fairness and bias and security and stuff like that. The other group, it's a bit different. It's just AI is just, sort of like as Andrew Yang says, it's like the electricity right now. Like no company says, hey, I'm an electricity company. Why? Because I use electricity, right? It sounds ridiculous because electricity is ubiquitous. And I think AI is at that point as well. So when I think of it, to answer sort of answer your question, I think the way to move forward, and definitely the future of healthcare and solving administrative burden and making more with less resources, right? We have a huge shortage of primary care doctors in the country, and we need to help. There's different solutions for that, but one of the ways we can do it is we can help doctors be more effective, and also help make the life of primary care doctors much easier by using AI, and we should keep pushing that forward.
No, I appreciate that. I think it's it's a very difficult problem to solve for, because we know that it's going to be a part of the way we do our work in the future, right? The way healthcare is delivered in the future. And so it's something where, we want to be thoughtful and intentional in how we approach it, because again, as we see with most any resource, it can be misused, it can be abused, it can be misaligned with our shared, kind of vision for the future. And so it is really important that we're being cognizant of the potential, pitfalls and challenges. I think it's something where, it's going to be an evolving, process as we move through. But I am certainly interested to hear both, Lisa, you and Sarah, your thoughts, and I'll turn it over to Lisa, if you don't mind just giving your thoughts on, how do you feel that, regulators and other key stakeholders should be addressing AI? I know that's, certainly something that's part of the landscape for the work you're leading. So would love to hear your thoughts on that.
Well, first and foremost, I'm really excited for us to get past the hype cycle of AI. We're almost there. Here we're at the top of the the peak. I'm hoping that that's true, because I think it's a real mistake to focus on a particular aspect of technology, right? All of the advanced work we do with data is really important for achieving outcomes, right? Whether it's reducing administrative burden or truly increasing and improving health outcomes. Any other focus, any hyper focus on AI for AI's sake is not going to get us there. The healthcare system is already incredibly expensive. We already spend plenty of money on technology. If we truly believe in the ability or the promises of AI to reduce sort of the cost basis, whatever that means to you, good and bad, then we should believe in that and make it happen and not inflate the cost of healthcare further. So first and foremost, I'd like to say that I think it's important. Then on the sort of governance and the regulation side, well, right now we have a total dearth of, of legislation and regulation to sort of control the way that AI tools are expand across the entire economy, but specifically in healthcare from the federal side. And that's a choice. There, the administration's been very, very clear. Congress has been very supportive that they really don't want to put any brakes or any limitations there. And what happens in the United States is that we have stuff happening at the state level. Here in California, we have Governor Newsom has signed into law multiple laws recently that are regulating and legislating and regulating AI in healthcare and in other parts of the economy and other parts of our society. And the problem with that is that it gets really tricky if you're developing tools or delivering software or whatever it is, when you have a patchwork of regulations and legislation and limitations otherwise. So that is challenging. We knew it was going to happen, and here we are. I think yesterday or this week, California became the first state to regulate chat bots that teens can access for things like, communication or behavioral health or whatever else it is, which is probably very needed. It's a very, very tricky area of development of these tools, not specifically in healthcare. So, we're going to see it's very complex to have a patchwork of state laws and have, a lack of legislation and regulation at the federal level. I think finally, I would just say when we look at the health systems and hospitals that we work with at Innovaccer, we see a total variation of how those health systems have governance models around the way that they bring AI tools into their practice. And that is also very challenging. There isn't like an amazing source of standardization, nor could there be, because every sort of health system and healthcare region across the country is different. So that's challenging as well. So that's what we've seen at Innovaccer so far in the last year or so.
No, that's really important stuff. And I mean, again, what we see happening within respective states, again, are they creating, favorable trends, unfavorable trends that others will want to follow? Do we leave it at the state level? Is it something that we set from a federal standpoint? I think there's so many questions to be asked and answered. And certainly, Sarah, I welcome your thoughts on the same topic, really just thinking about, how do we make sure that we're using AI in an effective way, but it's also a trusted source for our clinical teams. And I, just before we segue on to the next thing, would certainly welcome your input.
Yeah. I think physicians often feel like the last line of defense to protect patients from harm. And this is starting to get very complicated. We all want AI that is trustworthy and responsible, but this technology is very new and it's evolving by the moment. What's true today may not be true tomorrow. And so driving towards those goals of trustworthy and responsible AI can feel like we're hugging sand. And we want to protect clinicians and their patients. And to do that, I think there are probably a few steps we should take. As Lisa was saying, the federal government has not really taken a strong position on this so far and is leaving it more up to the states, which creates a lot of complexity and makes it difficult for clinicians to know what to expect. But even at the federal level, the FDA's approach to certain health tech AI and then ONC's certified EHR technology criteria for AI can differ in scope and in rigor. And so making these expectations consistent would increase clinician trust and smooth adoption. And we really need one coherent set of standards across agencies and keep refining them yearly as AI matures. So focus the standards on what clinicians need in order to trust AI: safety, privacy, accuracy, usefulness, clarity, and then enforce those things. And then, there's certainly a fair amount of clinician and patient concern about data privacy when it comes to AI. And of course, AI must still comply with HIPAA and established security practices, and agencies should align on frameworks like NIST, the National Institute of Standards and Technology, so expectations are consistent and predictable, and so that clinicians know what to expect rather than listening to the rumor mill.
Yeah.
Absolutely.
Drew, can I add one thing on this as well, just to
Absolutely,
reiterate
please.
again what Sarah was saying? Not only has the Trump administration, been very clear about they do not want to put any barriers up. They want to spark innovation. They want to, let this expand as quickly as possible. They've actually come out against some private sector efforts to provide sort of frameworks and guidance, which is the Coalition for Health AI. There's been a lot of criticism directly from the Trump administration, from the Secretary of Health and Human Services to others across the administration about the efforts to provide sort of a private sector governance and policy body. Some of those criticisms may be, justified, some maybe not, but the administration has got even further than just saying, we don't want to regulate AI. We don't want others to regulate AI either at the federal level, which is interesting.
No, it is. I think everybody's treading cautiously, which makes sense.
Right.
But at the end of the day, you eventually have to get involved. And I think
Yes.
as mentioned throughout the conversation, I think it's going to take a thoughtful, coordinated, concerted approach. Interestingly, we have obviously our prepared thoughts or questions, and it's mirroring some of what we're seeing through the chat in terms of questions. So I'd love to, Sarah, if I can stay with you on this one and then kind of go around the horn again. One of the things that we were thinking about asking the group is really about, a shift towards standardizing or optimizing health technology with the cost of implementing these tools. And certainly would value your thoughts on that. And what we're seeing in the chat is, again, how should health ecosystems reimburse AI solutions? How do you make sure that smaller healthcare providers like FQHCs or others can participate in these advancements from certainly from a cost standpoint? So I was trying to bundle it all because I know we're getting through the conversation pretty quickly and we're going to be out of time pretty soon. So I don't know, Sarah, if you can kind of put a bow on kind of the costs around AI solutions and some of the technology advancements and how it could be more equitably accessed by different folks, different practices, different entities, regardless of kind of their financial footprint or their scope or scale. So certainly we'll turn it over to you and get your thoughts.
Yeah. Well, going back to what Lisa was just saying, I think clinicians and healthcare organizations really are thirsty for a framework they can use to evaluate AI and other new technologies. So, small practices in particular lack legal and technical expertise to vet new technologies, and then they wind up with all this sunk cost chasing vaporware that overpromises but underdelivers. And the health tech industry was already flooded with a field of 1,000 blooming flowers. And AI has opened up even more opportunities to build solutions we've never even imagined before. But we really need to keep in mind how many tools to do how many jobs through how many vendor contracts a small practice can afford and manage. And that doesn't even include the workflow fragmentation that accompanies having so many disparate solutions. So this is why, going back to what I was saying in the beginning, I think it's important that EHR companies are leaning into the concept of being AI native. If they can bake these solutions into the clinician's living room, where we spend so much of our time, then most of the tech that we use in a day is on a single platform. This ideally optimizes both the experience and the cost. It turns out that doing that is actually much harder to do super well than imagined. So we'll see how it plays out over the next 1 to 2 years. But from a policy standpoint, I think when regulations are aligned and easy to understand, clinicians spend less time deciphering them and more time caring for patients. So we need clear, unified guidance to reduce the cognitive burden for everyone and even let technology teams then build better workflows that clinicians actually want.
Absolutely. Yair, I'd be really interested to hear your thoughts on that as well in terms of just access, certainly from a fiscal standpoint, how can entities, be able to access the technology that's going to be at our fingertips, but maybe is not as financially feasible for some versus others when it comes to these efficiencies or solutions. So just curious if you can kind of weigh in on the topic.
Well, it's an interesting question, but I think it's going to be a bit of a moot point and very fast because I think a lot of the technologies we're talking about are quickly becoming commodities, right? Like even if we look at ambient scribing, if you go back even definitely 3, 4 years ago, but even 2 years ago, it was an extremely premium product that health systems were paying over $1,000 per month for an AI-based electronic scribe, right? And that sounds crazy today. So I think there's always going to be a gap, and that's always true. There's always going to be a gap between the most cutting edge platform and solution and equitable access. There's going to be some lag, but I think in general, and I'm sorry, I sort of sounds like I sidestep your question, but I think in general, the important technologies are on a great curve, and hopefully, as Lisa mentioned, we get to the interesting part of the hype curve, right? And that's when it becomes really exciting and useful.
No, absolutely. And no apology needed. I think the big thing, and you make a great point about, hopefully as more and more competition comes into the market, prices will be driven down. And hopefully we'll see some really thoughtful disruptors, if they're not already with us today, that are going to help us really make sure that there is kind of good, equitable, universal access to the resources that are going to improve care delivery and certainly experience on both sides of the, clinician-patient equation. And so, Lisa, I'm curious, just to round out the conversation on this topic, your thoughts, and then I do have a really good question I'm going to kind of finish up before we get into some of the Q&A from the audience, but definitely would love to hear your thoughts on some of the fiscal considerations and other things as it relates to these technology advancements.
Yeah, so I want to actually cite the excellent AI prognosis newsletter from STAT. Just 2 days ago, there was a really great version of this from Brittany Trang from STAT, which is about the reality of implementation of some of these AI tools in different types of clinical environments. And specifically, the first example that she gives is from North Country Healthcare in Northern Arizona, 11 clinics, FQHC, piloting piloting ambient scribes, what that looks like, and truly just talking about how, of course, the cost was a huge barrier. Obviously that cost is going down, Yair's right. This is becoming commoditized very quickly. That is urgent because these tools do definitely help frontline physicians and clinicians. They don't necessarily reduce the full administrative burden, but it's at this point, and I think when we saw ambient scribes come out of the market, it was very much like, the house is burning down. Like we need there, it is so urgent. It's so urgent to have anything that will make life even a little bit better for frontline physicians and clinicians. That it was definitely, I've heard so many physicians tell me how it truly transformed their time and their ability to have even a tiny bit of extra time. So that was really urgent. But when you look at this example, and I really recommend folks read this newsletter and just read this example, they really talk about there were some benefits, but fundamentally the challenges that all of these companies will have that don't have the underlying data infrastructure is that you can't just slap it onto a system and expect it to work and reduce administrative burden. The issues we've all talked about needing the right data at the right time and being able to know what you're missing potentially, know what isn't there for safety purposes, that's going to still be there, even if you put a nice, helpful AI-based tool like an ambient scribing solution. So the cost is important. We have to get that cost down. I would say just specifically to FQHCs or those in lower resource environments, it's more important that you do anything you can do to solve your data issues than it is that you sort of bring in the latest, greatest, fanciest AI tools that are being, advertised to you. The data issues are fundamental to any type of tool. And then some of these tools might also be helpful in reducing burden. But I would start with the data issues, especially if you have few resources.
Very good points, Lisa. And I 100% agree that, the data is really, that's going to drive decision making. It's going to drive, actionable insights and things of that nature. And so it's a really insightful point that we really do have to focus on the data and figure out ways to make it meaningful and manageable. So the question I really wanted to pose to the group, and I know I've kind of varied the order, so everybody's kind of getting a chance to start us off, but I'm going to just throw it out if anybody wants to jump in, but let's look 5 years ahead into October of 2030. So as we're 5 years ahead and we're looking back and reflecting on the 5 years that's transpired, what do you think has been accomplished in the healthcare landscape, particularly around primary care? So what do you think primary care is going to look like 5 years from now? And what do you think primary care teams might be doing 5 years into the future that they're not doing at present? And so, again, I know it's not an easy question to answer. Nobody has a crystal ball, at least not that I'm aware of, but certainly would welcome input. And I'll leave it open to whoever wants to start us off.
Yeah, I can go because I actually have a crystal ball. So I just
perfect. Well,
earlier. And it went super hot take. It said that in 5 years from now, we're going to have agents as part of the team, as part of the care team. And we're going to have maybe 50% of interactions, first interactions for the patient in primary care is going to be AI based and agentic. So, all of those messages to the doctors, or maybe even simple triaging tools, are going to become commonplace. That's what, my crystal ball just said.
I would agree. I think your crystal ball has a good eye towards the future. I think the technology resources that are advancing in front of us very rapidly, I think are going to be a complementary resource in the future to make it where access becomes a little bit easier for folks. We know that that's one of the many challenges facing primary care today is just challenges with patients getting access, having the right access at the right time. And so the hope, and I think you articulated really well, Dr. Lewis, is that in the future we're going to be using resources like agentic AI and others to help patients navigate a very complex system and to also offload our overburdened clinical teams. And so certainly, Sarah, Lisa, I don't know if either one of you would like to jump in off Yair's comments.
Yeah, I mean, I don't have a crystal ball, but I have hopes and dreams. Last week I was at the AAFP's big FMX conference, and I went to a panel discussion about AI. And one of the panelists, Dr. Jen Pena, said about AI, we are throwing a very powerful tool at a dysfunctional system. and it has the potential to make that dysfunction worse. And I think these words of caution, we really need to heed carefully. What I want is a 2030 where AI is used for clinical augmentation, for human connection, a future where AI clears the obstacles and makes way for a more powerful therapeutic alliance, better informed, complex decision making, more proactive, collaborative, and coordinated care. And I really hope to see PCPs shifting from these data processors and data inputters to trusted interpreters and coaches and guides. AI can serve up insights, it can summarize care journeys, it can make evidence-based suggestions to better inform clinical decisions, all in a matter of moments. And it can identify and predict risk and prevent crises. It can synchronize information across the healthcare spectrum, consolidate treatment plans, assign tasks based on roles. I think that we have an opportunity to see primary care more connected to social services, more integration into care plans of like non-medical needs, more broad consideration of drivers of health beyond what we can throw a pill or a procedure at. And primary care teams will be navigating that community-based ecosystem with their patients, proactively managing populations, and increasingly evolving to meet the needs of an aging population that eventually is going to become digital native. So, and AI is going to mature along with that. So, as we see AI start to gobble up the administrivia that we currently experience in healthcare, we don't want our dysfunctional, volume-driven system of today to inform how we use that extra time tomorrow. That's not the path to better health outcomes, but we have some decisions to make, and we'll need to be very intentional about those choices.
Yeah, fantastic points, Dr. Pastor. I think, as you mentioned, we want the resource to be complementary, not competitive. And I think, as we can all appreciate, working in healthcare, a lot of the success hinges on developing strong relationships, trusting relationships. And so we want the tools and resources at our disposal to be really centered around that. And I think you bring up some really great points about exercising caution as we move ahead into the future. Lisa, I know we're getting close to the end of the hour. We definitely love your thoughts. And I don't know if you also have a crystal ball or if Dr. Lewis is the only one. But yeah, if you have any thoughts on what the future holds for us.
Yeah, I don't have a crystal ball, but I'm increasingly concerned. I share Sarah's perspective here on what I would like to see. I want to just flag for people, this is a little bit negative, so apologies for bringing us down. When technology companies say that they want to keep the human in the loop, that is because they don't want to take on the liability, the medical liability for outcomes. And I think that's just incredibly problematic, right? I think humans need to be in the driver's seat and technology needs to assist them. But I think we should just make sure we know that when we say that, when you hear that in marketing talk, it's because there is liability that physicians in particular hold as it relates to medical care that we haven't figured out we don't figure out what to do. We don't know the answer yet. We actually genuinely don't know the answer when something bad happens driven by AI versus something bad happens driven by clinical care from humans. We haven't figured that out yet. So I expect and I hope it isn't bad that we figure that out in the next 5 years or so, because we need to have an answer for that. And we can't just say, sorry, physician, an AI algorithm did this, but you're in the loop, so therefore you're responsible for this. So we got to figure that out. I'm worried, and I think we kind of need to do that in the next 5 to 10 years here. I also think the worst case scenario is that we accept that we won't be able to meet the primary care needs of Americans or people across the world, and we just say AI agents is all you get. I want a lot of my care to be things that I can direct myself and do and see on my phone and whatever else. But I know when I when I want to, when something is really serious, I certainly want to be cared for by a human, and I believe many people do as well. And so I'd like to find that balance, and I hope we can get there.
Yeah, no, I appreciate the optimism and your thoughtful
Sort
response
of.
there, Lisa. It's there's no perfect, but I think we're all striving for progress, and so it's great that we're having these discussions, having these considerations as we move forward. Right before we wrap up, I know we have just a few minutes left. Just throwing it out there as kind of a parting thought. Is there anything that you would like to share with the listeners today, the viewers today, about where we are at present? I know we just kind of took a little look ahead, but where do you think, or how do you think technology could really be beneficial in empowering our primary care teams, and kind of thinking about team-based models or other novel ways that we can use the resources today as we progress into the future? So just throwing it out there as kind of a last elevator type of 20-second, 30-second thought before we adjourn.
I got a one-liner, which is demand better technology for primary care.
Perfect. One-liners work really well, catchy and easy to remember. Doctors Lewis or Pastor, any parting thoughts on what we can do today to really position our primary care teams and kind of team-based models of care to be better for the coming future?
Well, I'm a big fan of something I call comprehensive care planning, which means that everyone involved in contributing to clinical decision making, care navigation, care planning for a patient, and that includes the patient, should all be focused on a single unified plan of care. So we're all singing from the same sheet of music. And from that plan of care flows task assignments and closing the loop and all the things that are involved in care coordination. That includes the things that the patient is supposed to do. And there should be two versions of this, one that faces the clinical team and one that faces the patient and patient-facing language, so that the patient knows what to do. Because health is not happening during that 20-minute office visit. It's happening when the patient goes out into their life and knows what to do. And then the rest of us are working in the background to help navigate that patient and make sure that they are getting the best care at the right time by the right person.
Absolutely. And Dr. Lewis, any parting thoughts on what we can do at present to put us in a good position moving forward as it relates to technology and primary care?
So I'll just add to what Lisa and Sarah already said, and I'm just going to go with the one-liner. We need demand better data. So we need, as Lisa said, we also need better data. So we're making sure that the platforms we're running have access to the right information, and we're not wasting resources on acquiring information.
Absolutely. Well, want to just thank all of you for your time and expertise. The time has really flown by, and we've gotten through a lot of content. I know there's a lot ahead of us in terms of exciting opportunities and challenges to navigate, but definitely want to thank Ms. Barry, Drs. Pastor and Dr. Lewis, again, for your time and expertise today. At this time, I'm going to turn it over to Todd for final thoughts and to wrap up our session.
Yes, thank you so much, Drew, and thank you to Lisa, Dr. Lewis, Dr. Pastor. Really appreciate you all joining us today and the robust conversation. I'd also like to go ahead and thank our colleagues and friends at the Commonwealth Fund and Arnold Ventures, whose support helped make this webinar possible and who are helping support our broader work on administrative burden. So thank you to both of those organizations. Just as a reminder, we will be sending 2 follow-up surveys, one about the programming for this webinar, and the second with some questions for you about your personal experiences with administrative burden. And finally, just wanted to let you know that our next webinar is scheduled already. It will be November 12th, and it will be our 2025 evidence report release. Oh, that is the wrong date. It is November 12th at 1:30 p.m. And it will be exploring the current state of primary care in rural communities. So we hope you can join us for what should be a very important conversation. And in the meantime, we will look out for your responses to our survey and look forward to reconnecting with you all soon. Thank you very much and have a wonderful afternoon.